So we have your wheel, we have about Beyonce today. But if you look at all her styles, all they are total necks. So I think it's really fun because he goes with my team today, okay? So my pronouns, I think that is new. So I want to tell everyone it's they, them. So I'm just transitioning. So please be mindful of that. But otherwise, it's okay if you made a mistake, just apologize maybe and we can continue, okay? So we're gonna talk about this case. So 36-year-old patient, assigned female at birth, 39 weeks pregnant, come to the ER in active labor. And they say, I have to push and push. I'm ready. I want this baby out of my body. And you look at their genital area and you see that it's fetal head crowning. And despite pushing with contractions, the fetal head goes back in and there's no advancement in the perineum. And you don't see any nuchal cord there. What you're gonna do? You're gonna get scared because I get scared. This is one of the things that sometimes every now and then I come to CCT and I review, what can I do? I have some things that I review. This is one of them also like, pulse also. Every time that I go to pizza, I'm just like, let me look pulse again, just to be sure that I know what I'm doing. So yes, we're gonna talk about shoulder dystocia today. And the most important objective of this lecture, if you're gonna learn something, is that please don't freak out, okay? We have all the resources to take care of these patients, and also you need to call for help. If you're in the community, if there's no OBGYN, sometimes if you work in other places, the OBGYN doctors are not in-house, okay? You're gonna have likely midwives that also are gonna be the people that you can come to the ER, so you know that you can count with some people to help you to deal with, that it's not gonna be only you, okay? So before we discuss actually shoulder dystocia, I wanna talk about quickly about the normal movements of delivery, because of course we learned this in our GYN rotation. You remember when you go to delivery? Yeah, okay, so yes, say yes. We're gonna talk about first, so the first part is gonna be engagement, flexion, and descent of the fetal head. The second part is gonna be, let me see here. B is gonna be the internal rotation of the head. Also, the occipitus is gonna become anterior. Then in this one, you're gonna see extension and delivery of the head. And then in here, you're gonna have external rotation. And this is where shoulder dystocia happens, in between these two stages, when you see a delivery of the head and then the external rotation, and then you're supposed to see delivery of the anterior shoulder. But that sometimes doesn't happen when you have shoulder dystocia, okay? And then after the anterior shoulder is out, the posterior will follow, and then the baby will come out easily, okay? I don't know if you, I think that doctors have sometimes this like desire to do a lot all the time. I catch myself sometimes like going to the room and doing something very stupid because I just want to do it, I don't know why. So, but for vaginal deliveries, you don't have to do really that much, you know? So if the head is like out, you just like support it, and then here, you can like actually do upward traction, and then with the anterior shoulder is out, you can do downward traction, and then the baby's out already. So really, sometimes you don't have to do anything, you just have to be there just to catch the baby in most of the cases. And then you can have this dystocia. That is a very rare complication of vaginal delivery, just really scary to actually face that. Less than around 1% of the births actually have shoulder dystocia. So that is like really small number, thinking about how many births in New York City we have, or in the world also. So that is a pretty low. And then it's when the anterior shoulder gets impacted on in the maternal symphysis. And then really the definition is when you need to do a, one second, one moment. It's when you need to do any OB maneuvers to deliver the shoulder, the anterior shoulder. So that is really the definition of shoulder dystocia. When you need to do something else that just like downward traction or upward traction is not solving, okay? So that is, it's very simple when you think about it. It's just, if you have to push your hands, that is a shoulder dystocia. You have to like call it already, okay? And that is the most important thing. And we're gonna talk about that soon. And then it's an emergency, it's an OB emergency, and it's very unpredictable and unpreventable event. there's no way to know that you're gonna have a shoulder dystocia. There's like risk factors that increase your risk, but really there's nothing to say, this patient can have shoulder dystocia. So is one of the risk factors is diabetes, elevated BMI, that you have multiple pregnancies in the past, post-term gestation, prior history of shoulder dystocia. The most important fetal risk is having macrosomia that is often related that the carrier has diabetes, okay? But no matter what, you can have all these things and you may not have shoulder dystocia, and you can have zero and you can have shoulder dystocia, which is like pretty terrible in my opinion, because we always like to know the likelihood of things, so what is gonna happen in the ER, so I think that is scary. So what you're gonna see in the physical exam, you're gonna have turtle sign that is defined when you see the fetal head coming out, and then you see that it's just retracting again, or it's not advancing, okay? Another thing that you can see is that difficult to deliberate the face and the chin of the fetus. So it gets stuck in there and nothing is like moving. Also failure of restitution of the head, that is actually extension of the head. When the head is outside already, there's supposed to be a little bit of extension of the head. If that is not happening, that also can be a sign of shoulder dystocia. And then there's also that the shoulder is not getting down. Of course, you're like stuck in there, head is out, and the shoulder is not getting out. That is like, it can be shoulder dystocia. And there's always been this definition in books multiple times talking about that physical, when you have the babies, is the head and the shoulders to go out are taking more than a minute. So you have the head and you're waiting in there to see if the shoulder will come out, and it's taking more than a minute. That can be associated with shoulder dystocia, but ACO said that this is not definitive and we should not rely on that to like call a shoulder. So it's really gonna be your physical exam where you're looking at it and how you see like the head is not moved, the shoulder is not going down, despite that the head is out completely, and you're like in the neck contraction, nothing come out, you should be aware. Sometimes you should not be waiting until the neck contraction because it's 4 to 5 minutes in between. So if you see retraction and you see that is something is stuck in there, you have to go for shoulder dystocia, okay? So what you're gonna do? What do you guys are planning to do if this happened to you? Huh? But what else? That is the only thing that you're gonna do? My brother? Okay, so what else? You have to first communicate with your team, okay? This is gonna be, everyone in the room needs to know that you're dealing with a shoulder dystocia, because if not, then you're completely alone in this case. And you should be with everyone in here. I maybe cry a little bit inside me if this has happened to me, to be honest. This is very scary. For OBGYNs, this is like their cross every day. They're just waiting every day that it's not a shoulder dystocia in their cases, because it's really hard. And what you're gonna do, call for help, okay? This is the time that you're gonna call a code 54. It's gonna be a trauma level, code 54-1. You need them immediately downstairs. You need anesthesia aware that you may need the OR also. And also you need PEDS aware that they're gonna have a baby that maybe needs to be resuscitated. You can call your colleagues in the PEDS ER. Also, you can call the PEDS team that they can come and assist you also, okay? You should have a bunch of people in the room because you may need all of them, okay? So the first line maneuvers is McRoberts, which is like the easiest one to do. And that is the reason that is the first maneuver. So it's gonna be hyperflexion of the patient legs at the hips sharply to the abdomen. And this is gonna open the symphysis pubis, and it's gonna flatten the lumbar lordosis that happen when you are pregnant. So they work like this, yeah? So there's like, because their body is that way. So when you do this, you like decrease that and there's more space in there for the baby to accommodate in there. So that can also be jointly done with suprapubic pressure, okay? So that will also help to like decrease the diameters of the baby's shoulders so they become smaller and they can move, okay? And we're gonna practice today so that it's gonna be good. Instead of just pressure, should be kind of like sliding. Like, because if you only put pressure, just like you don't actually doing anything, the baby's gonna get stuck with it. So when you put the hand, you can slide a little bit, it can help to move that shoulder away from the pubis. And that should help. 24%, this is gonna resolve 24% of the shoulder dystocia. That is not that much, but it's the easiest one to do, okay? So they don't require any like hands inside. It's easy, you can just need another person and that's it, okay? Second line maneuvers So important to note that first and second line maneuvers will resolve 99% of your dystocias, okay? And if you do it first maneuvers, second line maneuvers, and that doesn't resolve, you can start it. Like think about, okay, so I'm gonna repeat it again, I'm gonna do something different, I can repeat multiple times that algorithm, because the third line maneuvers are pretty scary. So thinking about that. This is the preferred one of all the OBGYNs. I talked to multiple of them, and I live with a midwife at home. So, and they always think that this is the best one to do. But I don't know, I feel a little bit scared putting my hands inside and grabbing something. But if I have to do it, I think that I will. So when you are in labor, the posterior shoulder and arm of the baby is gonna be flexed. So you can actually put your arms inside. You're gonna grab the hand, the arm completely, and you're gonna sweep across the fetal chest gently and withdrawing and straightening out. And it's gonna push the posterior shoulder out, and then the anterior shoulder will follow. Okay, so you're gonna go in, kind of like find it and take it out. This may cause a humeral fracture in the baby. That is okay. I mean, it's not okay, but they're gonna heal properly. So that should be something that you should not worry. If this happened, it's okay. It's better than having hypoxia and having a baby with other comorbidities after, okay? And the second maneuver is gonna be, oh, how do you do this? There you go. Okay, so this one is also another one that you can do. This is the preferred method where your anterior surface of the posterior shoulder is accessible, okay? So you can think that you can actually put your fingers inside in there, and then once there. So you can put your hands in the anterior aspect of the posterior fetal shoulder, and you can rotate in a clockwise degrees, 180 degrees, okay? So just like move the baby completely, and that will also create the space, and then the baby can come in an oblique way. So it's not gonna come like straight shoulders up, they're gonna come like hand to the side, okay? And that is also normal. What you want is just that baby out immediately, okay? The other one that you can do is Rubin maneuvers. It's kind of like the same thing, similar to this one, but it's gonna be, you're gonna place your hands in the posterior aspect of the anterior shoulder, okay? So it's gonna be in the top. So this one is, you see in the bottom, like the posterior one, so this one is gonna be in the anterior one, and then you're gonna rotate the baby around 30 degrees to the chest side, okay? And that will also create another oblique angle to make the baby come out. You can also do actually both at the same time. So you can put your hands in the fingers in the posterior aspect of the posterior shoulder, and then in the anterior aspect of the anterior, and you can rotate, okay? So you can do whatever you can do to move the direction so you can get that shoulder out, okay? This one, I think that is one of, it can be actually very useful for us because this can only be done in patients that are able to walk and they don't have epidurals. And that is most of our patients in the ER. So you can actually put them in foreleg positions. They're gonna balance themselves in hands and knee, and then you can apply gentle downward traction or upward traction in the shoulders of the baby, and that also make the baby come out, okay? And then last resort maneuvers, these ones are the scary ones, can be clavicle fracture, episiotomy, painful, and symphysiotomy, also just breaking the symphysis pubis of them if you need to, which is like terrible. And the next one is Savanelli. That is basically pushing the baby inside again, okay? Because there's no other way that you can take the baby out. So you're gonna take the fetal head, and in the occipital position, in the anterior position, you're gonna flex it and then extend it and then push it in, okay? And if you're gonna do this, the OR needs to be ready. This patient needs a C-section stat, and there should not be any time waiting for. And I would likely do this with GYN at bedside already. Like they say, oh man, we try all these things and nothing happened. We need just to take it to the OR. Let's push the baby inside. So complications for the carrier are gonna be uterine rupture, postpartum hemorrhage, also like a lot of damage to the cervix, vagina, bladder, urethra, anal sphincter on the rectum, and then symphyseal separation. That is like something that is really painful later, that they're gonna need like pelvic rehabilitation for years to be able to go back again to their normal self. So that is something to keep in mind. And then for the fetus, it's gonna be brachial plexus injury, facial nerve paralysis, Horner syndrome, clavicle fracture, humeral fracture, permanent brachial plexus injury. And the one that is really, this like the last two is like hypoxic ischemic encephalopathy and the death of the baby. And for, something to have in mind that this is like very high risk of litigation also, especially for the OBGYN. And this is something that they're like scared for that reason, because if it happens, it's unpreventable, it's unpredictable, and then you end up with a lot of like backward, like a lot of things happening to your career later. And if you have to remember something, I never learned words like that. I can't relate to that, but I know that some people like that. So for A, we can do ask for help. L is gonna be lift the legs. That is actually Mark Roberts with suprapubic pressure and then anterior shoulder delivery. Then you can rotate them with the wood screw or Rubin maneuver. You can take the posterior arm out. Or then you can also think about maybe a episiotomy if they think that they need more space, or even with all the maneuvers, if everything is really tight, then you can break the perineum and then you can go straight down, you can go to the side. That would be really painful for them, but if you have to do it, you have to do it. And then you can repeat it back again, like at least 2 times or 3 times before like thinking, okay, this is like stuck, we need to like go to the OR. But at this point, you should have OBGYN at bedside. If you are in the community, no matter what, you should have like a midwife or something, and someone that have way more experience than you doing this. And then that will be it. Look at the shoulders. So